The priority problems for a patient with AFib are 1, potential for embolus formation due to irregular cardiac rhythm, and 2, potential for heart failure due to altered conduction pattern. So the first thing we're going to talk about is prevention of embolus formation, again, which is clots. Drug therapy is often effective for treating atrial fibrillation. The goal or expected outcome for preventing embolus formation would be for the patient to remain free of embolus formation by restoring regular cardiac conduction. Traditional interventions for AFib include antidysrhythmic drugs to slow the ventricular conduction or to convert the AFib to a normal sinus rhythm. Examples of these drugs include diltiazem, which is a calcium channel blocker, amiodarone, beta blockers, which you know you're familiar, end with that LOL. And there are 4 types of beta blockers you can find on chart 34-4 used to treat dysrhythmias. Flecainide and propampanone can be used also for rhythm control of AFib. And we're talking about problems with clotting, so then we address the clot itself. The primary healthcare provider weighs the benefit of anticoagulant use versus the risk of bleeding. So a lot of times these patients will be on warfarin as anticoagulation therapy. And warfarin is nothing new to you. You know about vitamin K, you know about monitoring INR. Patient may also, or if they have problems with warfarin, they may use novel oral anticoagulants such as apixaban. So when you're reviewing these medications that are used for dysrhythmias, again, focus on the ones I talked about, be able to recognize their drug class, and then any special patient teaching or nursing considerations regarding that medication. All right, so moving on to preventing heart failure. The expected outcome for the patient with AFib is that the patient will remain free of heart failure by restoration of normal conduction with a controlled ventricular rate. Non-surgical interventions most commonly include electrical cardioversion, left atrial appendage closure, radiofrequency catheter ablation, and pacing. So first we'll talk about electrical cardioversion. Electrocardioversion is a synchronized countershock that may be performed to restore normal conduction in a hospitalized patient with new onset AFib. The cardioversion can be scheduled electively for stable AFib that is resistant to medical therapy. When the onset of AFib is greater than 48 hours, the patient must take anticoagulants for 4 to 6 weeks before the procedure. So, and the reason for that, if you think about the problem with AFib, linking and remembering that AFib can lead to clots, is that we don't want a clot to be hanging out in the patient's atria, and then when we shock it and get it back to a good rhythm where it gives a good squeeze, it's just going to squeeze that clot through and put it into circulation, causing possible stroke or PE. So if the onset of AFib is greater than 48 hours, the patient must take anticoagulations for 4 to 6 weeks before the procedure to prevent clots from moving from the heart to the brains or the lungs. If the onset of AFib is uncertain, a transesophageal echocardiogram may be performed to assess for clot formation in the left atrium. And so in terms of electrical cardioversion, what exactly is it? So it is a shock, but it's administered at a specific time so that it doesn't throw the heart into a lethal rhythm. So it's a synchronized shock, meaning it monitors what the normal heart rhythm's doing, and it lines up with the QRS complex with that peak, with the R, and starts timing that so that the shock is given where the R is going to occur. Because if it misses, or if it's not lined up, if it's not set to be a synchronized shock, it can put the patient into a lethal rhythm. The shock depolarizes a large amount of myocardium during the cardiac depolarization. It is intended to stop the re-entry circuit and allow the sinus node to regain control of the heart. Emergency equipment must be available during the procedure, and the patient should have signed us an informed consent. The defibrillator setting should be set to synchronized mode. So the same machine that you would use to defib a patient is the machine that you will use to perform a synchronized cardioversion. So it's important that the machine is set to synchronize, because again, if you forget to put it on that synchronized mode, it will deliver a shock whenever you indicate you want it, and it could be at the wrong time, and it could put the patient into a lethal rhythm. A dot or line will be indicated over each QRS complex, confirming that it is in synchronized mode. This avoids discharging the shock during the T wave, which may increase ventricular irritability, causing VFib, which again can be a lethal rhythm. For safety, before cardioversion, turn off oxygen. For safety, before cardioversion, turn oxygen off and away from the patient, because a fire could result, and shout clear before shock delivery for electrical safety. Therapy is repeated if necessary until the desired result is obtained or alternative therapies are considered. If the patient's condition deteriorates into ventricular fibrillation after cardioversion, check to see that the synchronizer is turned off so immediate defibrillation can be administered. And we're going to talk about treatment for ventricular fibrillation in a minute. Nursing care after cardioversion includes maintaining a patent airway, administering oxygen, assessing vital signs and level of consciousness, administering antidysrhythmic drug therapy as prescribed, monitoring for dysrhythmias, assessing for chest burns from electrodes, and providing emotional support and documenting the results of the cardioversion. For patients who are high risk for stroke and who are not candidates for anticoagulation, the left atrial appendage occlusion device may be an option. The left atrial appendage is a small sac in the wall of the left atrium. It is the most common site for blood clot development, leading to the risk of stroke. Inserted percutaneously via the femoral vein, a device to occlude the left atrial appendage is delivered via a transeptal puncture. So again, it is the left atrial appendage closure. We're talking about in the left atrium. After insertion, anticoagulation with aspirin and warfarin is required. A repeat TEE is performed approximately 45 days after insertion to assess for leaks around the device. If no leak is detected, the warfarin is stopped and antiplatelet therapy continues. Another procedure is radiofrequency catheter ablation. It is an invasive procedure that may be used to destroy an irritable focus in the atrial or ventricular conduction. The patient must first undergo electrophysiologic studies and mapping procedures to locate the focus. Then radiofrequency waves are delivered to abolish the irritable focus. So again, a focus, or topic focus, would be a site that's creating impulses. That's not the normal SA node. In AFib, the pulmonary vein isolation and ablation creates scar tissue that blocks impulses and disconnects the pathway of abnormal rhythm. Patients with AFib with rapid ventricular rate not responsive to drug therapy may have AV node ablation performed to totally disconnect the conduction from the atria to the ventricles, which would then require implantation of a permanent pacemaker. AFib ablation should not be performed if long-term anticoagulation is contraindicated. Biventricular pacing may also be used. In terms of surgical interventions, patients with AFib with heart failure may benefit from the surgical maze procedure, which is an open chest surgical technique often performed with coronary artery bypass grafting. Before this procedure, electrophysiologic mapping studies are done to confirm the diagnosis of AFib. The surgeon places a maze of sutures in strategic places in the atrial myocardium, pulmonary artery, and possibly the superior vena cava to prevent electrical circuits from developing and continuing AFib. Sinus impulses can then depolarize the atria before reaching the AV node and preserve the atrial kick. The surgical maze procedure is being replaced by catheter procedures using a minimally invasive form. The catheter maze is done by inserting a catheter through a leg vein into the atria and dragging a heated ablating catheter along the atria to create lines or scars of conduction block. Patients having this minimally invasive form of the procedure have fewer complications, less pain, and a quicker recovery than those with the open surgical maze procedure. I'm going to let you look over the care coordination and transition management section on your own. There are boxes on page 682 that you definitely want to look at also when studying.